Now, the advantage of biomarkers, as we have heard in the past days, they help identify individuals at risk for, so this is actually where most efforts should be directed to prevent and may have the greatest impact, of course. Biomarkers are useful to identify people that are at early stages of the diseases, can potentially be helpful in differential diagnosis and monitoring disease progression, and also biomarkers that are representative of a biochemical or an affected pathway, biological pathway, can be very useful to understand which pathology is in the patient, and to determine the clinical efficacy of new neurodegenerative therapies. As I said before, advanced neuroimaging techniques are typically only available in large medical centers of heavily urbanized areas and are expensive. And most clinics are not capable of conducting lumbar puncture, which is per se invasive for CSF biochemical markers. So, as I said before, the time of diagnosis is too late to begin with a neuroprotective strategy because most of the neurons have been lost, and that's why there is a need of reliable biomarkers that are indicative of the pathological process before symptoms manifestation. Now, as we heard in the previous session, Dr. Platt has mentioned the multifactorial nature of neurodegenerative diseases. Actually, if we look at Alzheimer's, Parkinson's, Huntington's disease, etiology, but not only neurodegeneration, but also not only neurodegeneration, but also in stroke, traumatic brain injury, spinal cord injury, aging, and malnutrition, we have similar pathologies which include inflammation, accumulation of iron, and the iron is actually the redox active iron increase, which through the Fenton reaction causes increase in reactive oxygen species. There is also glutamatergic excitotoxicity, mitochondrial failure, dysfunction of the ubiquitin proteasome system. I should have included also of the autophagy system, both systems that are in charge of protein management, abnormal protein folding as a result of a dysfunction in these systems, a decline in growth factor levels, which are very important for neuron maintenance, which all of them lead to oxidative stress, metabolic impairment, iron dyshomeostasis, DNA damage, and eventually mitochondrial membrane permeabilization and neuron death. So, as we see here, neurodegenerative diseases and other neurological conditions, aging, malnutrition, it is difficult to determine which of all the processes that I have shown is most important in triggering cell dysfunction and death, and what determines the selective vulnerability of the neurons. Because if we are talking about Alzheimer's disease, cells are dying, neurons are dying in certain areas of the brain, the cortex and the hippocampus. We are talking about Parkinson's, the substantia nigra, dopaminergic neurons in ALS, more prone the motor neurons, and so on. So the present perception of neurodegenerative diseases is that there are multi-etiological progressive disorders involving various pathological and molecular events which occur either in parallel or sequentially. So again, coming back to the picture that showed Dr. Platt about the cascade, the strong cascades and the small cascade, it means that all these processes are part of the big cascade, and we are going to treat neurodegenerative diseases with a single drug or single bullet drugs that are directed towards one cascade or two cascade probably this is not the correct way to do that, and we need what is called a multi-target approach, multifunctional approach for neurodegeneration, not only also for diabetes, for cancer, which we are aware of the cocktail therapies that are being used. So I will present, I want to stress one point. What we are doing in our lab is try to determine if a blood-based gene signature would accurately diagnose Parkinson's disease in early unmedicated and medicated based on this biology-driven approach that I told you to find the main pathway, the main pathologies that occur in the substantia nigra of Parkinson's disease patients. And this is just to show you that we begin our studies back to 2002 with our collaborators from the functional genomic unit in International Hospital and also in Germany. Our collaborator from Germany, and this shows you an asymmetric study where the substantia nigra, you can see that all the genes, if each row is a different gene, we have thousands of genes in the chip, you can see that the substantia nigra tissue clusters together and the cerebellum clusters differently. It means that the expression of gene is different in the two areas, so we can nicely show it by doing this microarray studies profiling. And if you look, for example, at these two patients, these are Parkinson's patients. So not only they classify far away from the cerebellum, they classify together differently from substantia nigra from control patients. So this is a nice way to continue and show, for example, that if we pick the main affected genes in the nigra and we go to blood and we try to find whether the same changes occur in blood, in the periphery, we have found a signature consisting of 5 genes that can differentiate between control and early medicated and non-medicated PD patients. And if we look at an advanced stage of the Parkinson's disease, so this marker, because this signature become even more strong. And when we compare to a population of 30 for Alzheimer's disease patients, the signature classifies the patients having Alzheimer's disease as being controlled. This is a 100% differentiation with Alzheimer's patients, and this graph actually shows you how the algorithm that we use can differentiate between control and Alzheimer's from Parkinson's patients. And I'm finalizing my talk because I don't have time. Concluding, pathway-specific phenotypes of what we call endophenotypes may have implications for targeted therapeutics for subgroup of patients with a particular disease mechanism. For example, if you have patients that have an inflammatory profile, so these patients may benefit from treatment with anti-inflammatory drugs. So this is one kind of work that we can do to enrich a clinical trial or differentiate patients that may be or may not benefit from a drug. So large multi-center studies are working to evaluate the diagnostic value of the combined application of biomarkers with multiple modalities for prediction, targeted prevention, and evaluation of disease-modifying therapies in neurodegenerative diseases. So just before I finalize, this is the last slide, which shows where we are, our collaborators. We are following those patients which came to the clinic unmedicated, and what happened not only as a progression, as the disease progresses, but also what happened with this profile while they are receiving drugs, for example, Rasagiline that was developed in our center, which appears to have a disease-modifying activity, how Rasagiline will change this signature as this